Good evening, everybody. We'll continue today with our journal club. The paper that we'll be looking into is your healthy, which is the efficacy of heel lift versus calf muscle eccentric for mid-portion Achilles tendinopathy.
A little bit on the background of Achilles tendinopathy. Your Achilles tendon is actually the strongest tendon in your body, but it is still one of the most frequently injured tendons in your body. And it's most common for rupture. Morphily et al. Actually define Achilles tendinopathy with three elements, which is pain, swelling, and functional impairment. And Magnan actually found that Achilles tendinopathy is actually a degenerative, not an inflammatory. That's why we don't call it tendinitis. Alright, so the risk factors of Achilles tendinopathy can be divided into intrinsic and extrinsic. Intrinsic could be your age, sex, body weight, systemic diseases like diabetes, rheumatoid arthritis, the muscle strength and flexibility, any previous injuries, and your blood supply, which is dependent on your genetic. Drugs, extrinsic will be like things like drugs and such as your antibiotics, and overuse where there's any frequent microtrauma. So there was a paper that actually looked into the hypothesis of pathogenesis, and if you can look at this, it shows you there's multiple hypotheses, which is your neurogenic, angiogenic, compression, and also iceberg hypothesis. All these are only hypotheses, which shows that we're actually very far from actually understanding this tendinopathy issue. Alright, so the objective of this paper itself was to compare the efficacy of in-shoe heel lifts into the calf muscle eccentric exercises to reduce pain and improve function. So these were their main objective: pain reduction and function improvement. So the methods they went in using was a parallel group randomized superiority trial, and they randomized each participant to one of the two groups. Either group A will be a heel lift group that will receive this particularly specific, clearly adjustable shoe heel lifts, which were 12 mm in height, or an exercise group that will be advised to carry out a calf muscle eccentric exercise program for 12 weeks. Okay, so this is the clearly adjustable heel lift together with a covering, and this will be the exercises that they had done. I will go into specifics after this. So they were randomized using the cloud-based randomization, and a 1-to-1 allocation ratio was given. Right. So the in-shoe heel lifts, they used this specific Australian heel lifts, and the study was done in Australia. They were given each participant up to 3 pairs, and 3 sizes were available dependent on the participant's shoe size. Each participant will be advised to remove all existing insoles in their shoes and to only use these insoles when as much as possible, and the height of it is 12 mm. For the exercise group, it's based on Alfredson's method. They are given a video and a handout, and each participant will require a small step of at least 20 cm off the ground to perform this program. You're supposed to do it twice daily, 7 days a week for 12 weeks. In participants with both side symptoms, the exercise program is done both sides. From an upright body position and standing in with all your body weight on the forefoot, your ankle joint is moved into a plantar flexion, and the calf muscle will be loaded eccentrically. This will be done with knee bent and also knee straight. Okay, so participants will avoid any concentric loading by using another block which is 10 cm high. So the opposite leg will then concentrically lift you up, and then you put weight onto your problematic leg and eccentrically lower down, and then again your opposite leg will lift you up, and so on. So 2 positions, knee bent and knee straight, and it involves 3 sets of 15 repetitions. And if the pain and discomfort has reduced, then you're told to increase resistance by using a weighted bag backpack with 5 kilo increments. So the modification of physical activity, both groups also receive modified physical activity program, which is safe and produces comparable outcomes to programs that involve complete rest. And you can do your normal activity as long as the activity doesn't cause you to have pain above 5, your pain score of 5. Okay, so the study population, actually the participants were recruited from an advertisement in newspaper and social media. It was between September 2017 and December 2017, and they were all conducted in a University of Discipline of Podiatry in Melbourne. Okay, so the inclusion criteria was must be above 18 years old, Achilles tendon symptoms on one or both legs for a minimum of 2 months, pain score of at least 3 out of 10, must be literate in English, using footwear regularly, able to walk household distances more than 50 meters without any aid, willing to attempt to not use any additional treatments such as your shoe modification, physio, injections or any surgery in the next 12 weeks, willing to attempt to discontinue all pain relieving medications, and you have to come into the center for 3 occasions. So if you're willing, then they will include you. The exclusion criteria will be currently pregnant, previous surgery, chronic ankle instability, any systemic issues. Other than that, any breast cancer, uses of antibiotics within the last 2 years, any use of heel lifts, injection of local anesthetics to the area, any medical condition that the investigator thinks is unsuitable, and any cognitive impairment which will make it difficult for them to answer the questionnaire. Alright, so how do they diagnose Achilles tendinopathy in this paper? It was an insidious onset of pain at the region of Achilles tendon, which is aggravated by weight bearing. Pain must be located 2 to 6 cm from the insertion, and then an ultrasound is done by one single person to show that there is local thickening or irregular fiber orientation and hypoechoic areas around the mid portion of your Achilles tendon. Okay, so this is the algorithm. When they do an ultrasound, is there any hypoechoic area? If yes, tendinopathic. If no, then they will look for focal thickening. If both also no, then you're excluded. Okay, so the outcome measures were taken at 2 weeks, 6 weeks, and 12 weeks. The 2 and the 12 weeks will be at the center. 6 weeks they had given a postal questionnaire so that the patients didn't need to come. Primary outcome was your visa A. If patient is bilateral Achilles tendinopathy, then you do for the most painful side. Secondary outcome measure will be your Achilles tendon structure via ultrasound, severity of pain on your WAS score, your health status using their questionnaire, magnitude of physical activity in the previous week, a 7-day recall. So this is the questionnaire that they had used, they had mentioned in number 3 here, which is your Euro quality of life, 5-dimension, 5-level questionnaire. So the 5 dimension is your mobility, self-care, usual activities, pain, discomfort, and anxiety, depression. And 5 level is we have scoring of 1 to 5. The lower the score, the better the quality of life. Okay. So other than that, your calf muscle function at baseline at 12 weeks. This test is done by the maximum number of repetitive unilateral weight-bearing raises that could be performed until fatigue using a metronome. Self-reported treatment effectiveness and for pain and function, I will show you this later, and use of paracetamol as rescue medication. So this is the patient impression of change scale. So 1 will be very much improved and 7 will be again the worst outcome. Alright, so in this study, so it's a bit blur. So eligible, those who had come in was 368, however they excluded 268 via the exclusion criteria, and they got about 100 participants. Minimum for this paper was supposed to be 92 lah, to get a good outcome. Then they randomized 50 equally to give the heel lifts and eccentric exercise group. At 2 weeks follow-up, there was loss to follow-up 9 on the heel lift group and 8 on the exercise group. Then at 6 weeks follow-up, there were only 39 on your heel lifts and 34 on your exercise group. And finally, when they had to come back to review, assess again with the ultrasound, 40 on both sides. So they had lost 10 and 10 over each side, but they analyzed all 50 together. So this is the primary and secondary outcome measures that they had tabled. So the ones that we are looking particularly with the p-value of less than 0.05 is your VISA A, and your severity of pain, here, your your Euro quality of life 5D5L index at 12 weeks, and also the severity of pain was scored. Right. So primary outcome measure, they found that 80% follow-up of participants at 12 weeks, and the mean VISA A improved for the heel lift groups of 26 points and 17.4 points in the eccentric group. So they showed that there is lesser improvement in your exercise group. However, on average, there was between a difference in favor of the heel lifts for the VISA, but they also mentioned that they are not sure whether this value is significant enough to say there is a difference in both of the groups. Secondary outcome, most of it were not statistically significant. Only statistically significant was, as I showed earlier, your WAS score in favor of the heel lift and also your Euro quality of life, but only the index score in favor of the heel lift. What I found interesting was the self-reported adherence. I think this is the main issue when we come with the faced with the eccentric exercise group, will be the adherence to exercise in comparison to something that is just fitted into your shoe. So if you realize, you can see that the adherence actually dropped throughout the weeks and finally at 60% in comparison. So this is only 2/3 in comparison to the other group. Many reasons, but nothing was cited in the paper. Okay, so for me, in this paper, they had mentioned their own strength, which was bias was minimized, there was an appropriate sample size, the participants of the study were representative of your individuals in public, and but they did mention that further studies are required to see if subgroups such as younger or higher, those who are more active, and interventions are really ready. They say that something good is that both interventions are readily available. Okay. So limitations that I saw in this paper were, one, blinding is definitely not possible. The study population were generally the public. They are not athletes, and they were also recruited via newspaper or social media. This means that these patients who they had recruited, one, they didn't seek medical treatment, so chances are maybe their symptoms were not as bad. Two, it's not everybody who has social media or newspaper work. So it doesn't cover the full population in the general public. The other thing is, for the exercise group, they had mentioned that they had given video and a pamphlet. It was not taught to the patient, and it's unsupervised. So you don't know what the patient is doing at home, the participant is actually doing at home. Number 4, blocks that were used were not provided. So you don't know what, again, I say it's unsupervised. You don't know what actually the patient is actually doing at home. Number 5, progression of exercise group. This I found important because as a participant in the group of the exercise branch, every time you had less pain or less discomfort, you're told to progress. So when you don't have pain, you're telling the participant, do something till you have a little bit of discomfort or pain. So in that sense, VAS or your VISA A will be affected because you're expecting them to progress it over time. Whereas the one with the heel lift is just something same. When the pain is reduced, you just continue. So this is some biasness which I don't agree with. Number 6, lower self-reported adherence. As I mentioned earlier, the adherence was lower, but they had not put this into the calculation of their statistics. 7 is reduced dorsiflexion may lead to change of your biomechanics. With heel lifts, you're already putting the foot into a plantar flexion position. So if you're putting it there, your amount of dorsiflexion of that particular foot would reduce. This will then increase your stress upon your patella tendon and everywhere else of your lower body biomechanics, and it can cause you more adverse events in the future. Maybe not short term, but something in the long term. And this treatment is only short term. They only saw it for 12 weeks. So, yeah. From other papers, I actually found that, as I mentioned earlier, if you reduce your dorsiflexion up to only 8 degrees, you can affect your knee joint kinematics. And if you shorten your gastrocnemius length, it will increase your Achilles tendon stiffness. So this Sapo et al. In 2010, actually it did it on habitual high heel wearers. It's just to show that reduced gastrocnemius length and increased stiffness can affect your ankle range of movement, and then over time cause you discomfort when walking in flats. Mayer et al. Also showed that there were no difference in pain measurement over the pain or PDI index between physiotherapy and heel lifts. And finally, in exercise, you actually find that structural tendon adaptation, tendon length changes, and all the other neurochemical alterations, neuromuscular adaptation only happen during eccentric muscle exercise. In heel lifts, it's just something that is passive, that will not increase all this adaptation and no positive effects in that sense. So for me, in conclusion, this paper was something that we could maybe look into short-term treatment for those who have very severe pain to reduce that acute pain. But this cannot be used for long-term because of the side effects that it could affect to your biomechanics and also cause future issues.
Okay. Cheryl, if this was your study and this was your design of the study, what do you do to make it better?
What did I do? Maybe in some sense will be a crossover study where those who use heel lifts will then go into exercise eccentric to see whether the long-term effect, or whether it is just that that particular group has. I think mainly the issue will be adherence. So whether the heel lift will adhere to eccentric exercise.
So why do you think the adherence is so good?
Because it's something you have to take time to do. It's something that is painful to also do because you're already having tendinopathy, and the eccentric component of the exercise will cause you more pain. And it's difficult for people. I think mainly it's the time.
Okay.
It's time.
What do you think of the protocol used here in the Rabusin?
Protocol used in this.
What do you think of this protocol?
I think it's very tedious. You have to do it bent, knee straight, multiple times a day, 7 days a week.
Very good. Will you read the original Efficacy paper? Okay. The original Efficacy paper was done in high school or college athletes, which means patients are of fit population, and at the get-go, if you do this in this population, if you do this protocol, it may work. But my concern about the original paper was it's too high a volume for a rehab protocol. Okay? Because if I were to ask any one of us here to do the same amount of volume just for 1 week, no one can do it. Because it is actually very high volume. Alright? And now you're adding on to a population that is in pain. Okay? If you look through the population profile, none of them there appears fit. The average BMI was 28. The waist to hip circumference was 0.9, which tells you already this patient has probably never exercised properly in a very long time, right? In this population, this protocol is not ideal. Thus, this can also explain why the compliance is so poor. Okay, so if you also read subsequent papers onto that person, they actually did a 5-year follow-up on the paper. So the 5-year follow-up on the paper, half of the population actually received complementary rehabilitative activities onto their person now, which already tells you that the person alone is not the person. Okay? In fact, other papers comparing our person, they actually just did that protocol and they say, do as you think is okay. Meaning you do, I already okay, go already, you stop. So the volume is self-adjusted. Actually, the outcome is the same. So the protocol itself is not appropriate. It's not appropriate. And if this paper you read through like that, you may think, why the exercise don't come out better? But if I read through the population that is selected, right, I think this outcome is appropriate. Because in this population, never exercised before, moderately overweight or obese, with one or multiple comorbids, I think heel lift is the level. Yeah. Right. So this paper is good for patients who just not want to exercise. But do you think after this 3 months is over, will the pain go away?
No, definitely not, because you're not doing anything to actually help with the adaptation of the tendon itself to heal. You're just resting. It's in a resting position in a shortened.
But when I don't remember, right, what was the secondary outcome? Did they mention anything at 3 months, whether the heel lift wearers had any tendon changes morphology-wise?
No. They did an ultrasound, but there were no changes seen outside.
Right. You should expect some changes though with healing.
Yeah, that's right.
Which means it's
2020.
quite a new paper.
Yeah, that's right.
Sounds
No, it is. It was. That's why I just about it. Yeah. Never mind, it's okay. It doesn't matter.
but it's good.
Yeah, because, exactly.
Then what is the principle why you actually applying the heat for
Is for you to reduce the length of your Achilles tendon, to reduce the strain and pain.
to reduce the length of the tendon be
Shorten.
shortened,
It is shortened, so the pain is reduced.
but if you remove the heel,
Yes.
it will be improved.
I think that is dependent, but when they're doing their activities and it has shortened Achilles tendon, the pain is reduced. But these heel lifts are usually not used during exercise or sporting activities. It's supposed to be used throughout, just on a daily activity level.
You know, I understand is during the Achilles tendinopathy rehabilitation, we want to
Yes,
better
correct.
So
Correct.
how,
So this
why this works short term and without much exercise is because when you shorten that length, when you're offloading the Achilles tendon, so the pain does really temporarily. The easiest way to make this paper much more completed would be for the next 3 months, remove healing, remove exercise, and monitor the patient. If there is improvement with the healing, then I will tell you healing very good. But if there is a return of pain right now, I tell you that's just classification. Yeah, it will be better than a control group. But just the same people, the one that did the eccentric exercise, the 60%, and the one that did the heel lift, just remove it. Within 1 month, you should be able to see the difference really. Who has actually more pain, who has less pain. That will make the people a lot better, like my opinion.
I can see patient having a return of pain.
Yes.
Yes. So the main one that they looked at and the positive statistically significant one is the pain. It didn't state on function. It didn't state on long-term outcome. So this paper is pure. I think and I feel after looking at this paper is something can be used for short term, just to reduce your severity of your pain, and then to move on to something else. But this is not a long-term treatment, and it's not something that will help in the progression, the disease to halt the
explain? Yeah.
It's only comparing both technique in this paper. Like Cheryl mentioned, maybe in the short terms it will help the patients in terms of the pains, but the ones for the long term effect need more long. I mean they can do another study like that, see the long term effect of using the. They can follow up the patients after 3 months. They can follow up the patients, both of them, and then see whether the pain is still increase or is continue to reduce.
Jadi ada apa pun buah-buah sampai. Silakan.
No paper though. No, I printed the protocol, the original.
Oh, the first paper. Yeah, they had a different.
They keluarkan their protocol before they did the recent study. Tapi the basic premise of it is they think that heel lifts will decrease the load through the Achilles tendon. While there is like a health relief, there's a lot for every study they quoted here. There's another study that says that it doesn't. So even the studies they quoted actually mix. Their result is actually mixed. Some of them, I think number 31 Nixon says that heel lifts causes in some patients increased load, some patients have decreased load. Because depending on if they're runners or not, forefoot, heel strike runners. So you couldn't prove the basic part that heel lifts decrease the tendon.
From what you just said, there's different populations of the other.
Yeah.
Because the population is active.
Correct. So
they
the other
they have proven preferred limit.
yeah. So the question becomes, can you use heel lifts or in both your active population, the sporting ones who get Achilles tendinopathy, and also these group of people who don't really do much, the non-active group. So actually these two populations have to be either studied separately or
They did mention that at the end.
so that is one of these part. The other part is they did a funny thing with, not funny lah, yes, they did a different thing with the statistics where they did not account for dropout. And they actually have a huge
Yeah.
number of dropouts.
The drop is very
And
high.
it's very odd because
They counted every 50, all 100.
yeah,
Yes,
so they
6.
started with 100, but by 6 weeks,
No, but at 12 weeks at 40 and 40,
Yeah.
they still counted it as 100.
so their 2 weeks, they dropped about 9 and 8 didn't count. Then the 6 weeks, 10, 16 and 11. Then at 12 weeks, it was 10 and 10 didn't count. A lot dropped out, but their analysis was an analysis of
50 and then they mentioned.
so when they used that analysis, they used the imputation analysis. When they do that, they use the computer to fill in the missing blanks of missing data. So number one, we don't know how much missing data is missing because they didn't say, maybe ada dalam the additional info. So when you don't know how much missing data is in and how much the computer could do, apparently you should have, what they do is they give you like maybe 20 sets of data with assumed data. So data set 1 to 20 and then they give you a result. Usually that's the standard lah. So they use 5. They had 5 imputations and only one of the 5 reached the goal of minimal important difference of fat to show that there is a difference between the two. So in that sense, maybe the statistics wise, there is some manipulation of statistics to give it a good show so they can write it out. Yeah. On the basis, I think what they can prove is in a 12-week session, both eccentric exercise and heel lifts decrease pain. Now one they could prove. They couldn't prove that one is better than the other. You could prove direction, means both of them are going in positive direction, not heel lifts make the pain worse. That's the only thing you can prove. So I have to be careful with the statistics on what they use here. And then actually there was another study with Jill Cook in 2015. They did a sham orthosis
Yeah, I read that
and
as
real
well.
orthosis, but they didn't say how much heel lift or not. They just say orthosis. But at the end of the year,
no difference. They gave them a depo orthosis and a real orthosis. There was no difference. Everybody did eccentric exercises. Everybody got better. The heel lifts didn't make much of a difference. So maybe it's
No, but that one will just point whether it's original or not original or but they both use orthosis.
Oh, bukan. Satu was based on the foot. They designed an orthosis. They had the podiatrist people made orthosis. The other one was totally Indian. They just gave like half, not a sham orthosis lah, not a real orthosis. So they didn't expect you to have any clinical effect from the issue of sham orthosis.
But to be fair, like 1 year from the way they start, like a lot of them got better already.
Yeah. So in the end,
1 year.
they said that there was not much difference from that. What about the effect?
I think this one is a sponsored company. That's why I kept saying it's Australian and that particular brand was the only brand.
No, it's not that. No, but that's how you read the research. You have to specify what brand of item you use, done from which manufacturer, which company, and which year.
The conflict of interest. No, so the funding they declared it from the university itself, but usually funding will have to go through your university.
They use the club to cut. They use the club to cut.
You have to still go through your university.
The other things they didn't publish their effect size. Yeah, because they publish their usually if your result is good and your effect size is good, it's the first thing you put up because it means it's clinically significant. If you decide to omit the effect size, most likely they didn't reach their goal. Yeah. It could also be because their number is small. So
But they said the minimum amount they were supposed to get was 82.
yeah.
But
So what they did was to plan it. They wanted 92, so they can get effect size of 0.59. That's moderate effect size. Means it should give you some clinical significance. When they didn't reach that number, they continued with the calculations, but didn't recalculate and publish what was the actual effect size. So even though it's statistically significant on